Good morning all, my name is Michelle Noon. As a subject matter expert in chronic disease, with emphasis to the escalation of obesity within our community, I have been selected to represent the public health in an obesity campaign with the intent to propose a health care initiative that obligates the control and prevention of the disease within a broad range of diverse populations within our community. With these objectives, I am speaking for communities of populations most at risk, as well as the influential, professional, and policymakers to illustrate a well-supported impact of the adverse effects of obesity and why it is crucial to handle this public health issue starting at its basics, continuing with effective legislation measures. Along with our crusade, the proposed policy will evaluate and illustrate whom will ultimately be affected by the policy, how the policy will discourse obesity, and what eventually will result by the enactment of the proposed policy. Lastly, the proposed policy will touch on the potential costs and benefits, effectual risk to public health should the policy not be endorsed versus endorsement, and how the policy will affect the at-risk. Despite policy measures on obesity, such as federal mandates on fast food distribution, state government enactments implementing nutritional and physical systems, and local governments executing regulations that govern the number and the locations of fast food chains, the collaboration of federal, state, and local governments employing improvement efforts in local school environments that obligate food vendors that are established in schools to vend snacks that meet a more active approach involving influential people, medical professionals, and effectual policy contributors is a necessity. Obesity is a serious public health concern. Through 2009 to 2010, accountably, more than a third of all adults and roughly 78 million adult individuals were considered and or diagnosed as obesity considerably. It is estimated that 1 out of every 5 youth or adolescents aged from 2 years old to 19 years old were determined to be amongst the obese. Obesity affects not only the individual, but also impacts family members, the community, the local, state, and federal governments, and healthcare systems. It also involves health insurance and food and beverage industries, etc. Consequential health impacts of obesity epidemic include, but are not limited to, a negative stigma associated with the disease, an abundance of preventable deaths and related conditions of the disease, such as diabetes, heart disease, some cancers, hypertension, sleep apnea, heart disease, arthritis, and linked physical, emotional, and social challenges. The built environment is a human construct of the physical environment or default conditions of the environment. The built environment includes the overcrowding and deterioration of urban environments, cities, and suburbs. The built environment has considerable influence on the overall health of the community and is a public health issue of most importance. Further, the impact of the built environment as determinant of obesity is the outcome effect of the physical components of where populations live and work, such as one's home, the streets, open areas, and substructures. These factors affect an individual's amount and desire of physical activity, thus adversely leads to disfavored health outcomes, such as obesity, diabetes, and certain types of cancer, etc. In light of overweight and obesity of epidemic proportions of both adult and adolescent diversities within our community, along with the considerations of associated risk factors to a ripple of chronic diseases, the construct of environmental and public health policy interventions that facets the community's powerful medical professionals and policymakers are essential. among other collaborations of legislation measures that focus on food industries and school food distribution methods. We as a community worked together with local and state researchers, conducted a key area populations mapping approach, addressing fast food chains, parks and recreation, as well as the availability of healthy food markets. We then established a census with the Board of Health and plotted specific data collection that focused on the ethnicities, genders, and both young and old age groups of communities from local medical professionals. As a result of these scientific measures, and as a speaker of the community, we propose a public health mandate on specific fast food allocated locations, accessible areas of recreation, firm educational measures distributed through medical providers, and strict policies that allow persons of various diversities to have free or at no cost transportation, as well as below cost community source gyms and/or diet treatments. Policy initiatives directed towards increasing public awareness of obesity is key. This proposed measure will ultimately assure a decline in the key contributors of preventable chronic diseases such as heart disease, hypertension, and some cancers, etc., simultaneously reducing the epidemic rates of obesity and diabetes for all ethnic and age group diversities. Once a national health threat like obesity is challenged, the government at the federal level can resource its funding to direct a national response that then develops a thorough response plan, affords data to advise the response, and a guide to funding for local and state level responses. As soon as the financial backing and data have been established, response levels can then implement policies that contribute to our policy that eventually festers obesity within our community. Research suggests that enthusiasts of competitive food policies commonly allow changes that abate a bill in order to counteract opposition, and which will ultimately attain stakeholder buy-in. In this vulnerable time of campaign and political elections, corporate and industrial contributors to various election statuses may possibly influence current health policies or propose public health policies that accompany restrictions on unhealthy food and beverage taxation, the advertising or marketing of considerably unhealthy contributors such as soft drinks, fast foods, and alcohol in at-risk communities. In closing, overweightness coinciding with obesity epidemic is a national concern, causing comorbidities that include type 2 diabetes for both our young and our adulthood Americans, as well as the offset of cardiovascular disease, hypertension, an array of cancers, other potential health issues, and mortalities for at-risk individuals, including those that are a product of our built environment. Not only is obesity a major public health issue, but the effects of the preventable disease cause a burden to the funding of our nation's healthcare system, costing the United States from obesity and associated morbidities a total of 1.2% of all gross domestic product. That is why effective health policies that address the control and prevention of obesity with a substantially diverse community that obligates a collaborated effort from the influential at the local level, the assistance of medical professional providers, that obligates obesity prevention education material, as well as policymakers, is essential. Controlling obesity in our community provides an assurance of improving the lives of individuals and families, not only within our community, but the nation as a whole. Our public policy initiative as an ulterior framework that embodies a role model for all populations. Thank you.